Thank you, Chairperson, and thank you for Dr. Nasif and Dr. 𝗏 الهنداوي for letting me present data from Hamburg about endovascular treatment of aortic aneurysm and dissection in patients with genetically triggered aortic disease. Most of connective tissue, especially Marfan, present initially with acute type A aortic dissection, and open surgical treatment for aortic root is well established with excellent long-term result, no debate about that. And for long decades, the guidelines from different societies insist on recommendation of open repair over 𝗘𝗴𝗆 in patients with Marfan syndrome and connective tissue or genetic trigger syndrome, except in emergency bridge for definitive surgical repair. This data from Hamburg Aortic Center, we collect consecutive data of connective tissue disease. We include 24 Marfan syndrome, 2 Ehlers-Danlos syndrome, and 5 Lohs syndrome over 10 years of practice. This is publication about Marfan syndrome. It includes 24 patients. Relatively, this cohort is old age and with a high rate of previous aortic surgery, about 88% of the cohort. To understand the analysis, we divide this group of patients into 3 groups: 𝗘𝗴𝗆 group, including 12 cases; hybrid 𝗘𝗴𝗆 early in this cohort, including 7 patients; and fenestrated branched 𝗘𝗴𝗆, including 4 patients. And you can notice that when we did 𝗘𝗴𝗆, we prefer landing zone 2, and we will explore this later. As regular we did in non-connective tissue disease, we use our adjunctive procedure to extend the proximal landing zone using carotid subclavian bypass or frozen elephant trunk, and maybe occlusion of the distal false lumen using candy plug coils or Knickboeker technique. The early outcome as regard the mortality, we have only 1 case of mortality in patient who received hybrid 𝗘𝗴𝗆 due to multi-organ failure. The morbidity looks high, but if we go through the details, most of them are minor complication like wound infection or access vessel complication. And as regard the gastrointestinal complication or renal failure, it occurs in hybrid 𝗘𝗴𝗆 group. And nowadays in Hamburg, the preferred mode of treatment is fenestrated and branched 𝗘𝗴𝗆. And as regards the survival and freedom from re-intervention, it's accepted at 1 year. The main concern is late re-intervention in this group of patients. Initially, when you look at this, we have 24 patients, 14 of them receive late re-intervention. But if we think in another way, dividing those re-intervention as regard the origin of them, we will find that only 4 patients related to the index previous repair and 10 related to the disease itself, because the connective tissue disease, especially Marfan, is continuing degenerative process. So we should think in this way that disease in another segment is not accounted as re-intervention. Here is an interesting case of Marfan syndrome. This patient received previously aortic root repair and descending thoracic aortic surgical repair with implantation of 1 intercostal artery. Then after years, he presented to our center with type 4 thoracoabdominal aortic aneurysm. We decided to treat this patient with custom-made branched 𝗘𝗴𝗆 with 5 branches to include renovisceral vessels and 1 intercostal artery, as direct perfusion of this intercostal artery protect against spinal cord ischemia. The other 2 cases of Ehlers-Danlos, they present to our center with thoracoabdominal aortic aneurysm, and they received endovascular therapy. The first case presented initially with acute type A aortic dissection and treated with surgical repair with bare metal stent in descending thoracic aorta outside our center. Then he presented to our center with thoracoabdominal aortic aneurysm and was treated with stage 𝗘𝗴𝗆 and T-branch. Here is follow-up CT finding. You can notice how the thoracic segment in upper images and the abdominal segment in lower image remodel over the year. The second patient initially presented also with acute type A aortic dissection and treated with frozen elephant trunk. 1 year later, he presented with thoracic aneurysm and treated with TVAR and 𝗘𝗴𝘆𝗃𝗃. 1 year later, he presented with common iliac aneurysm and received open surgical repair for 𝗟ω𝗴𝗆 bypass. And after 2 years, this patient presented with thoraco-abdominal aortic aneurysm and was planned to be treated with fenestrated EVAR and already done, but at the final angiography, there was type 1C endoleak. As you see in image B, this endoleak was related to both renal artery, but the condition of the patient at this time was unstable. He discharged to ICU and to home. And after 1 month, this was fixed by covered stent and relining of a stent of both renal artery. Here is follow-up CT after 3.5 years, and you can see that thoracic segment and abdominal segment with stable diameter. This was our single center data, but our colleague Dr. Isbanos was interested to review the literature and to compare our result to others. He collected more than 300 patients for TVAR and fenestrated branched EVAR and found that we have a favorable outcome. I can hypothesize this favorable outcome to strict precaution that decrease the stent graft related complication, like the use of low profile endograft, limited oversizing. We don't use ballooning at landing zone. And in some cases, we remove the stent at distal landing zone to decrease the distal radial force, and in consequence, decrease the risk of sign. During the analysis of our data, we found one interesting point that may goes against the concept of landing without synthetic graft. We found that in 5 cases of Marfan where we land inside the landing zone 2, no proximal landing zone re-intervention. While in 2 cases with Loeys-Dietz syndrome, we have type 1 endoleak that was fixed by proximal extension using a double inner branch stent graft in 1 and the frozen elephant trunk in other. To have a consensus on this multicentric study is needed and registering. One of them is GREAT that compare connective tissue disease patient to non-connective tissue disease patient and found that no significant difference in early and late outcome. We can conclude from from this presentation and from revision of literature and the practice in Hamburg that endovascular aortic repair, genetic aortic disease may be of benefit both in elective and emergent situation. Effort to decrease the stress of stent graft on fragile aortic wall may improve the outcome. Close monitoring by multidisciplinary team in specialized aortic center become valuable. Native proximal landing zone 2 for TVAR could be safe and with favorable outcome. More work is required to determine the applicability of these findings to genetic aortic pathology. One of them is EVICTUS registry, in which we are not the leading center, but we are included, and I think Dr. Germano also is included with his center in this study. Thank you. You can find in this QR code most of publication I addressed if you are interested in detail. Thank you again.